Hi, everybody. Welcome to tonight's session with Dr. Antonino Secchi. I'm Susan Duval, Clinical Affairs for GC Orthodontics in Europe. Thanks, everyone, for joining us today. Nice to see everyone here. Tonight's session from Dr. Secchi is Understanding Anchorage and the CCO System. Before we start, I just have a few housekeeping notes here. The duration of today's webinar is scheduled for about 30 minutes. This session is being recorded, and a link to this recording will be sent out to all of you who attended this evening and all those who did register so that you can view again or view it at your leisure. We've got quite a lot of attendees on the webinar tonight, so your mic access is restricted in order to avoid any background noise or unnecessary interruptions. We ask that during the session, if you have any questions for Dr. Secchi or comments, using the bar at the bottom of your screen, either the Q&A or chat sections, you can just jot down what your questions are, and Dr. Secchi will address them at the end of the session. So for those of you who don't know Dr. Secchi maintains a practice in Devon, Pennsylvania. He's a diplomat of the American Board of Orthodontics and a member of the Edward Angle Society of Orthodontics also. He received his DMD, Certificate in Orthodontics, and Master of Science in Oral Biology from the University of Pennsylvania, the same institution where he taught for over 10 years, holding the position of Clinical Assistant Professor and Clinical Director of the Department of Orthodontics. He's published in several dental and orthodontic peer-reviewed journals in the areas of treatment mechanics and straight wire appliance. He is the founder of the Complete Clinical Orthodontic System, the CCO System, and the Secchi Institute, which provides continuing education for orthodontics in the US as well as throughout the world. Loved to spend time with his wife, 5 children. He's a passionate photographer and loves to meeting people, traveling, and sports. Dr. Secchi, thank you so much for being with us tonight. And we really appreciate you being here, and feel free to start whenever you're ready.
Thank you. Thank you, Susan. Thank you, everyone, for joining us. So very interesting. We're going to be talking about Anchorage and the CCO. First of all, I would like to invite you because I will be with my dear friends Julio Garcia Baeza and Oliver Bill in Salzburg in June of this year, 7 and 8, 2024. So we will have a couple of days where we can talk extensively about the CCO. But talking about Austria, I had the pleasure to be there last month in March in Kitzbühel. And why I'm saying this, because that was a great meeting for the Orthodontic Society of Austria, and I had the pleasure to be there for a full day. In that meeting, actually came the question, how you manage the Anchorage? People were a little bit confused because I was showing these things that seem pretty difficult without any anchorage, and they say how that works. So when I got the explanation of the CCO and the 8 kind of fundamentals of the CCO system, you can see that number 3 says no need for anchorage preparation. And that is a very, very strong statement. I understand that. The first thing that we learn in orthodontics when we go to school is anchorage preparation. Still, when I went to school 20 years ago, I had to go to the Tweed Foundation to bend the wires and to understand anchorage preparation. So we will, I was showing at that time cases like this one, for instance, when people say, well, but how you prevent the incisors to go forward when you kind of align that canine? I mean, where is the anchorage? How you anchorage the anterior teeth or the posterior teeth? Or a case like this one, where severe crowding in the lower jaw, where you can see the lateral incisors on the lower left is almost like a completely blocked by the canine. How can you put a wire and just let the case go? I mean, what is the rationale? I mean, what's going to happen? How you anchor teeth? How you prevent teeth to blow? We will see that, or in a case like that with extractions, where I engage those canines, and I'm expecting that the wire is going to bring the canines into position. So what is the anchorage? Are you cinching the wire back? Are you putting a tat in the upper jaw? Are you using transpalatal boards? I mean, what is the anchorage for this situation to prevent the incisors to go forward or the molars to come forward, which is what people are worried about it. So all of these things, I guess, they cause a lot of kind of questions, and that's why we said, let me try to explain them a little bit in half an hour. I know it's a very short time, but since we're gonna be in Salzburg next in June, I said that's gonna be good to give a little webinar, so maybe people are more tempted to kind of join us in Salzburg. So CCO and the Anchorage preparation. So just to give you an historic perspective, as soon as we start taking teeth out back in the 40s with Charlie Tweed, he started coining this term of Anchorage preparation. And I'm showing in those slides there, the idea was to basically upright the molars and tip them back tremendously so they can anchor the front teeth from moving to unexpected positions. Then back in the 80s, we have Terry Root came with the level anchorage system, another way to do it with not straight wire, but with pre-programmed appliances. At that time, the rationale was the same thing: place severe tipped on those molars and premolars to move them back, tip them back, so we can control the front teeth while we were leveling and aligning. Interestingly, in the 90s, I have this slide from one of my mentors from the straight wire, and the idea was to show here that when we cinch the wire back and we kind of upright the premolars and the molars, we will control the incisor from flaring. That's actually, we used to call that the lasso effect. The molars will lasso the incisors, and as the molars and premolars rotate back and tipped, they will control the incisor. So there was a lot of ways that we wanted to sort of leveling and aligning, controlling the system. We added the straight wire, added a lot of rotations to the molars and premolars for anchorage. Now, those rotations made us pay a big price in finishing in many situations. Also in the lower jaw, as you can see here. So rotating the teeth back, cinch the wires back to control the premolars and molars to control the incisors. Also, in this sagittal view, you can see how I try to make these diagrams to emphasize that as the molars and premolars, they tip back and they were rotating back, they were controlling the incisor. So all of that was kind of the mantra of the straight wire back in the days, in the 80s and in the 90s. Then also MBT came with these ligatures, the lace back to control the canines were leveling and aligning in extraction cases. And I put this diagram from their book when they explain that the lace back are actually holding the canines so they can move back as they level to align the other teeth to prevent this flaring of the incisors. So very interesting. And then we came with the CCO, and I said, okay, with this system, we don't need anything of this. And people were like, what are you talking about? I mean, the anchorage preparation is in our DNA. I mean, how can you say we don't need that? So I'm going to try to explain why. So one of the very interesting thing is that anchorage preparation, it's all about how to manage the arch perimeter while leveling and aligning. I mean, this is a very important thing to understand, that is closely related to the interbracket distances behavior, how the interbracket distance behaves while you level and align. So is the arch perimeter increasing or decreasing while you level and align? You know that there are two teeth that they are very kind of misaligned. The wire from one tooth to the other will be a lot longer than if the two teeth are together in a very good alignment. So while you level and align, what happened with that interbracket distance? Are you keeping it or are you reducing it? And that is the reason why in some systems you need it before anchorage preparation, and that's the reason why we don't need it now, because we allowed those teeth to move together as they level and align, because the wire can translate to the bracket. So it's that simple as that, but that's something that needs to be understood. So again, all of that happened in the stage of leveling and aligning, where the main goal is to correct rotations, tipping, alignment, and start leveling the arch. And that is very important. So we use typically two wires. We use typically an 014 initial oil and a 2020 bioactive. In severe cardiac cases, we can also use an 018 initial oil in between. These are very sophisticated arch wires. And we will talk about that because that's part of also of the equation. It's not just one thing, there are many things. So here, my question is, what's going to happen with those teeth? When I engage them with the wires, let's say I'm mimicking an upper arch, can be a lower arch with crowding. What's going to happen? Are those teeth just going to blow up? And I'm going to keep the arch perimeter, meaning the distance of the wire from the distal of the second molar, all the distance until the other molar. Is that arch wire length will remain after I level and align, or is going to decrease? Because as you can see, there's a lot of wire between the front teeth because they are very away one from the other. So if you don't allow the wire to slide through the bracket, of course, the wire has memory, will just bring the teeth into alignment, keeping the same distance. And that is when I create flaring. If you sink the wire back, you still can start pushing the molars forward as you level and align, because the front teeth will just flare. And then you start building other systems in the back to increase the anchorage. If you allowed the wire to slide through it, the wire has memory, will just bring in the teeth together, and the interbracket distance will diminish, and the remaining wire will just slide all the way back. You can see that when we use this self-ligating bracket, like the experienced CCO, is metal. So you have a metal wire against a metal slot, a metal clip. When the wire is very small, there's very little resistance to sliding, which means friction. So the wire can slide really well. So you can see right here with the dimension of the slot. Also, you don't have to forget that the tubes, the molar tubes, are passive elements. That pretty much in every system since 1900. The tubes are passive elements. They don't grab the wires very well, specifically round wires. So the wires can slide back without any problems. The other thing is the amazing wires that we're using right now. These bioactive wires, these initial oil wires, that they have different forces from the incisors to the molars. These wires that they have super elasticity, and these wires that they can deform and change with the temperature are not the same wires that we had 30, 40 years ago. That's little video. I'm putting this bioactive 2020 in cold water, and the wire is completely dead. You can basically do what the girl is doing there, and then put it in hot water, and the wire in a second will reshape. Absolutely. So that's what's going to happen in the mouth. You bend these wires based on the crowding, and the temperature of the mouth start activating this wire and start releasing the shape. So the teeth start basically following the shape of the wire. And also, as the wire bring those teeth together, the wire can slide through the brackets, and you can see how the teeth can get aligned without secondary effects. So it's very interesting. So here, what's going to happen is that there's no question about the secondary effect of the forces. So as the wire reshape and the incisors come forward, Also, the upper incisors, the centrals, will come a little bit back. The canines also, as a secondary effect, will start coming back again, following the shape of the wire, and they will, if there's space, they will start going to the space. And all that will happen because the wires are able to slide back through the slot of the premolars and the molars. So as the wire bring those teeth together in the shape of the wire, the interbracket distance can reduce. The arch perimeter will get reduced, and the extra wire will just go back. And that is what basically is great, and is helping us to prevent any sort of anchorage in the posterior. So by the time we're level, we have basically the arch looking like that, and the extra wire will just clip it, specifically in crowded cases with extractions. Now, in non-extractions, we're using other things. The wires start unraveling the teeth, and that's why you need to keep an eye how the malocclusion looks at the beginning, so the treatment planning can many times call for a little bit of uprighting of the incisors and the premolars, as we will see in some of the cases. So this case that I'm going to show to you, I treated more than 12 years ago, and that was a case that opened my eyes on exactly what I just told you. When I saw this girl was basically a class 1 protruded, and my treatment plan at that time, 12 years ago, called for extractions of the first premolar. I don't want to give too much information about really the diagnosis, but it was a Bimax case. Today, I would have extracted the second premolar, but that's another discussion. At that time, 12 years ago, I removed the first premolar. And you can see what I did. I engaged the wire from the very beginning. After the extraction, put the braces and engage no anchorage. I have nothing basically holding that wire in the back. It's not cinched, nothing. And you can see how in 3 months comes like that. And you can see how in 8 months of treatment is looking like that without doing anything except just changing the wire. So what it caught really my attention was how the space between the canine and the premolar was getting smaller and smaller at every visit. And the only thing that I saw was just the wire protruding in the back. I have no elastic, no rubber bands, nothing. So then basically after leveling and aligning, the remaining space was very small. We just closed it and the case was really finished. No problem. So that's the case finished. That's 4.5 or 4 years after treatment. And that's the case, the cephalometrics. You can see how the teeth kind of align much better in the front. And of course, the lips looks much better when you compare the before and the after. So that case was really a revelation in that sense. So now, what about this case? So this case, as I showed you at the beginning, is also, you need to understand how teeth will move. You see the midlines are a little bit toward the lowers are deviated toward the canine that is down here. So as the wire bring the canine up, it's gonna move the lower incisors a little bit forward and a little bit to the left side to correct the midline. That's how we're gonna make room, and it's gonna happen just by putting the wire. Also, if you can see from the picture of the 45 degrees, I have a little bit of an overjet at the premolars on the right side. So that overjet will be solved because the premolars will upright. So I know that. I can see that it's gonna be uprighting. I see that I have space for the lower incisors to come forward, and I see that the midline, they needed to be corrected. And that's why I'm confident that if I put a wire, the wire will just reform the arch, will upright the premolar, will move the incisors, and will make room for the canine. In fact, in the upper, I already have that wire, and the next picture is the same wire, and I haven't done anything on the upper. So everything is just unraveling under the upper wire. It's one visit. And then you have another one, and that canine looks much better. The midlines are on. The overjet of the premolar, much better. And now you see that we're ready to jump to the next phase, which is arch coordination, which is going to be the theme of another webinar probably, or we will talk about that in Salzburg. So, and then we finish the case. So we need to understand where the teeth will move and what are the spaces that you have in the arch. It's not just putting those wires and let it go. So when you understand that, it makes it a lot easier. What about this extraction case? Also a canine that is completely out. I know very well that that wire is a heat activated, has thermoelasticity. So I put the initial oil in the lower, and that wire has to go out to go and grab that canine, and the wire will bring the canine in, because that's how the wire will reshape itself. So as the canine comes into the arch, the distance between the canine and the premolar on the lower right side will get smaller, because the wire can start sliding back. And that's how very confidently I can put the wire, no anchorage at all. And in 8 weeks, it comes back like this, and then like that with a 20/20 and then a 19/25. So without doing any effort, the canines start coming in, the space closed by itself, and I have a better alignment. And now it's just arch coordination, and then finish the case that actually you can see there with power chain. I close all those spaces, and then we remove the braces. So not very hard when you understand how the teeth will move based on the wires that you use, the bracket that you have, the system. So another case, very crowded. But watch this case, watch the incisors. The upper incisors and the lower incisors are retroclined. So I'm expecting, just by unraveling the arch, a little bit of a buccal crown torque of the upper incisors, or you can call it tipping. Yes, they will tip forward a little bit, and then on the 19/25, I can torque them without any problems. So before I start leveling the lower arch, I need to unravel the upper arch, because I have to make room for the lower incisors to unravel forward, because in this case, they can do that. So that's why I'm going to show you that severe crowding in the lower jaw. I decided to do a non-extraction, and I'm here unraveling the upper arch until I got basically this situation. When I have the upper incisor in a much better position, when the inclination of those incisors looks much better, and then I put the lower arch wire. So I know that the lower arch wire will do a couple of things. Again, I have an overjet between the lower premolars and the upper premolars, too much. And I know that those premolars will upright, because they were leaning lingually, they were upright backally. That's gonna give me a lot of space to upright the canines, and also to move the incisor forward, correct the midlines, because the midlines are toward the left, because that canine is completely out. So you start thinking about three-dimensionally how the arch is going to start unraveling. And I'm confident then that I can treat this case without any extractions, and just by basically unraveling the arches. So you can see how this case comes from here to here. A little bit better. The midlines are still off, but it's getting there. And then a little bit better. The midlines are a little bit better. The incisors are coming a little bit more forward. I have space. The premolar overjet is way better, because the premolars are uprighting. And you can see now I'm in a 20/20 bioactive, upper and lower, and the case looks much more controlled. And remember, the upper teeth have not moved very much since here. So I'm not flaring them out. It's pretty much the same incisors, and just the lower arch is unraveling basically under the upper arch, until I get to the 19/25 stainless steel, where I can coordinate the arches, consolidate the spaces, and now you see the overjet of the premolars looks uncanny, looks much better. And then we can finish the case later, and basically until we take the braces off. So you can see here the case finished. So what about this case that I showed too? That I decided in this particular case because of the full class 2, severe crowding, blockal canines. I said, I'm going to treat this case with an upper bicuspid extraction, some crowding in the lower jaw. That was my treatment planning. Now, how can I do this? How can I, after I remove those teeth, how can I unravel and treat the case? You have, there's many different ways. And I see today people getting really, really complicated because of the mentality that the interbracket distance will not change. So therefore, the teeth will just flare out because the distance between the canine and the lateral incisor will remain. Imagine if I don't allow the distance between the canine and the lateral incisor to decrease. The wire will just align those teeth and they will be flared out. And we don't want that. We want actually the canines to start coming down to decrease the distance between the lateral incisor and the canines, and they get into the space because the wire now is pushed out. So if you think that that's not going to happen, or you use conventional techniques when you just tie very, very tight the wire into the bracket with figure 8 kind of elastomeric ligatures or stainless steel ligatures, then you will have a different effect, absolutely. And then you start thinking about putting maybe touching the upper transpalatal bars, maybe just bring the canine by itself with a power thread or with a power chain, and all these very, very complicated things. While the only thing I need to do here is just put a 014 initially and just tell the patients come back, see you later. And when they come in 8 weeks, that's how it looks. I bond the lower arch, and it looks much better. One visit. In one visit, they can see the difference. And then basically a 20/20 bioactive upper and lower, and I got to the 19/25. And until this point, I have done anything except just remove the wires and put them back. And now is when I start basically closing the spaces actively. It's so small that I decided to use power chain and a class 2 elastic on the left side to correct the midlines and close that gap. The other space is almost closed completely. And that's what we did. So we put a power chain, we leveled the occlusal plane, we put the elastics, and basically we got the case to the end, final wires, and I took the braces off. So all these with minimum, as you can see, I mean, Anchorage requirements. So you need to think about that. You need to understand the Anchorage is basically connecting the dots, because it's not just one thing. It is about doing this in the leveling and aligning with a reduced friction system. It is about also use the super elastic, heat activated, very sophisticated arch wires. It is about understanding the treatment planning and the management of the arch perimeter, how that arch perimeter will work in that particular case. I want that arch perimeter to get increased. Can that be increased because these are very retroclined, or actually the arch perimeter has to be decreased because the teeth are flared, or it needs to be maintained because I like where they are. So how the alignment will react to that, or how the arch perimeter will react to the alignment. And the ability to change the interbracket distance is key in this system. Thanks to that, we can align these teeth without having a lot of secondary effects, as you can see in many other cases. So that's basically it. I know it's a very, very quick kind of for 30 minutes. And of course, we're going to be a couple of days in Salzburg, so I can't wait to go back to Europe and be with you guys in that beautiful city. And in the meantime, I would like to thank you very much. And if there is any question, I think we have some few minutes, maybe a couple of minutes to answer. So thank you very much.
Thank you, Dr. Secchi.
Thank you.
If anyone has any questions, don't hesitate to write them down in the Q&A or chat sections here. There is one question. Let's just give him some time to, if you would like to type that question out, Doctor. Okay. How do you prevent distal tipping of the canine while leveling?
Yeah, so very interesting. So distal tipping of canines. So the problem with the distal tipping of canine, the most of the time you see is when you actually actively grab the canine when leveling and aligning, let's say in extraction cases, and you start moving it back. I see that happening all the time. That I see a case with extractions. I see an arch wire kind of flexible, and I see whatever mechanism you want can be tied whatever with power chain, and those canals are coming back. Now think this: most of the time, the root of the canine in the upper jaw, in the lower, is in the right spot, and the crown is what you see is in the wrong spot. So many times the crowns can actually upright. Now, upright is one thing, and we want that to upright into the space. What you don't want is to tip them back. And tip them back is when you start actively closing the space by moving the canines too early. So my answer could be don't try to move the canines into the space with anything but the wire, because then you can actually tip those canines back, and it's really hard to tip them initially again.
Perfect. A comment, thanks very much. It's all very clear. You have a friend here saying, ciao, Antonino. Good job as usual. Big hug.
Oh, that's my dear brother, Rafael Spina. I love
Yes,
you,
yes,
man.
yes,
Thank
yes.
you.
And I believe there's a Greek doctor. His text came in, but it's in Greek, so I cannot read it. Just a minute. Let me scroll down here a little bit more. Dear Dr. Secchi, thank you very much for your explanation. Bioactive wires, how long do they stay in the mouth?
Yes, so I would say that typically we are placing those wires in leveling and aligning not less than 8 weeks. So typically my 014 stays in the mouth for about 8 weeks. Then when they come back, if the crowding was severe, I might go to an 018 for another 8 weeks, but I would say 80% of the times I just go straight to a 2020. And the 2020, I leave it for another 8 weeks, and sometimes another appointment. So I would say that in most cases, the leveling and aligning phase, in most cases, there's always different cases, but in most cases, is about 2 wires, can be between 4 months and 6 months. Of course, there are outliers that they will keep you busy for almost a year, leveling and aligning, and other cases can be done in 3 months. But for the most part, 2 wires and about 8 weeks each one. So in about 4 or 5 months, I'm pretty much done with the leveling and aligning phase.
We have two more questions here, and then I think we have to let you go because you do have patients piling up at your
Yes,
door. I think they're starting
I
to
do.
arrive.
I do. Yeah,
Okay, so
yeah.
two more questions. And what do you think about segmental technique with canine distalization and then engaging the incisors in the full system?
For the question was like how you
What do
do.
you think about using a segmental technique with canine distalization
Yeah,
and
yeah.
then engaging the incisors in the full system, I guess, afterwards?
Yeah, you know what? Again, I mean, there are many different ways to do that. Segmental techniques, they were on fashion, where the only wire that we had was stainless steel. So if the only wires, go back to 1970, guys, 1980, only wire was stainless steel. So how you can do some of those cases that I show you with just stainless steel wire? It's impossible. So people were very smart, and they start designing segmental mechanics, removing teeth, move a tooth in segment. Then when you have the segments closer to each other, then do a continuous arch wire. So I have nothing against those. I just think that it's an extra work that you don't have to do in these days. I'm pretty sure there will be one case that you might have to do some segmental mechanics, but in the everyday cases, I mean, I don't really find the need to do it, to be very honest with you. And it's because of that, because many of the segmental technique cases today, we can solve them with these super elastic cases that, I mean, wires that we have. Yeah.
And one more question, and then we're just going to have to let you go. Currently, I have a problem with a patient who is brachy and has a deep bite. It's difficult to align the occlusal plane. What advice can you give me? I am using the CCO system now.
Yeah. So there's no question about. So the quick answer would be use a very stiff wire in the lower jaw. I could say a 19 by 25 stainless steel, good quality, and place on the wire a very strong reverse curve. And now, of course, there are brachycephalics and brachycephalics. So from 1 to 10, I mean, yours might be 8 or 9. I don't know. But typically, that's the way that you level the occlusal plane. So the more brachycephalic you are, the deeper the curve of P that you will have, and the more reverse curve that you will have to add to the lower wire, to the mandibular wire. Sometimes, based on how the occlusal plane in the upper jaw looks, sometimes I do also place a compensated curve in the 19 by 25 in the upper. But most of the time, it's just working on the lower mandibular plane. So you have just to put more reverse curve and make sure that your wire is very stiff.
Okay, perfect. Unfortunately, there are a couple more questions there. For those questions, well, you can join us in Salzburg. That would be great. But if you can't join us in Salzburg, just reach out to your GC Ortho representative, send him that question. He'll make sure that I'll get it. He'll make sure that Antonino gets it, and we'll try to get you that answer. So once again, thank you, Dr. Secchi. I know you have patients waiting for you. I hope to see you in Salzburg also.
Thank you very
And
much, everybody. Thank you.
okay, have a great evening, everyone.
You too. Thank
Thanks
you.
for
Bye-bye.
joining. Bye-bye.